You're watching CTOM TV. Knowledge is power.
Dawn is wondering what the median overall survival is when you use the ciclib treatments. If there's a general sense of that, or even
I don't have it off the top of my head. Let me find. Now, it depends on what type of cancer you have, what stage.
Like furiously done.
Yeah, so that's a pretty in-depth question.
Is it? Okay, well, let's see.
I mean, we can definitely answer it, but it's also going to depend on your genetics and which CDK4/6 inhibitor you're on.
She says stage 4 IDC.
Okay.
And she's on ribo.
And she's on ribociclib?
Yes.
And what has she had as far as treatment, and how long has she had cancer for?
Okay. Couple more questions, Dawn. What else? What other treatments have you had? She was initially diagnosed in 2008.
Okay.
Now dealing with stage 4 IDC, has had surgery, chemo, radiation, and just waiting. So 2008. So that's a good long time ago.
Yes.
Now on ribo and letrozole.
Ribo and letrozole?
Yeah.
Okay. She should switch that letrozole to a fulvestrant.
Why?
Just because it's an estrogen alpha inhibitor. And if she's metastatic, she needs to be on fulvestrant. It's what's used for metastatic.
Okay.
Now she can stay on the AI as well.
That's the ribociclib?
Yeah, no, the AI aromatase inhibitor.
Thank you.
So you can take the aromatase inhibitor, fulvestrant. In fact, the aromatase inhibitor and the fulvestrant work really well together. They work better than either one alone.
Okay.
And combining it with ribociclib will give the full power to the treatment. Now, when she says metastatic, how metastatic? What organs? Is it just bones? Is it liver?
Just a waiting. In the fluid around lungs.
Sorry, lungs? Okay.
Yeah, in the fluid around the lungs.
Okay, Sarah. Okay, how about the liver? Is the liver okay?
No tumors there. Yes.
Bones?
Liver, bones. No, she says just the fluid around lungs.
Okay. Okay, good.
All clear otherwise.
Okay. Yeah, definitely. And get her to go on Zometa.
So that way we're kind of preemptively addressing any potential bone metastasis. Is that
well, once again, Zometa reduces the spread of the cancer, not just in the bones, but elsewhere.
Okie dokes.
It's the only bisphosphonate that has been proven to do that. So
for those of us in the back room, aromatase inhibitor, examples?
So there's steroidal and non-steroidal.
Oh, right.
The best ones are the non-steroidal. Yeah. The exemestane is the steroidal one. And what it does is it permanently binds the aromatase inhibitor, whereas the other ones temporarily inhibit the estrogen. So, estrogens, you want some estrogen production, and that's the thing, because it does bind the beta receptor. So you get more side effects from something like exemestane.
Okay, so can I just clarify what you just said for Dawn? Fulvestrant plus an aromatase inhibitor,
yeah,
plus the ribociclib, and then Zometa.
Yeah.
Okay. That's Alex's off the top. Now, just it's really important that everybody understand we're not looking at your medical records here. No. There may be nooks and crannies that are important for us to know. So, if you go to your doctor and ask about this stuff and you hit a brick wall or you get with any resistance, circle back around to us, have a consultation with Alex and allow him to write up a report for your doctor with the references to grease that wheel a little bit. Again, that's where our advocacy comes in. So by all means, go straight to your doctor and ask about these. If there's any confusion, uncertainty, resistance whatsoever, let us help draft some documentation for your doctor so they understand why these things are so important, okay?
Yeah, so just to clarify, when I'm giving you this information, I'm giving you the latest peer review studies that have been determined by all the scientific and medical community through what's called a continuing education program. In other words, this is assessed to have the best data. It doesn't necessarily mean that it's the best financial wise for your local hospital. It may not be, and it probably won't be. They'll probably say, oh, that's very expensive. It's not worthwhile. It's not worth the cost. It's too many drugs. The reality is that's what's going to be best for you as a person. It's going to give you the best chance of reducing recurrence and targeting your cancer. Without having genetic information, of course.
Sure, that is always kind of start with the genetic testing, ideally, or circle around and get it. You know what Alex just mentioned about cost. We can have a whole seminar about the ins and outs of medical systems in a variety of different countries and why yours is the way it is. And what's important to understand is there are numerous workarounds and ways through in terms of you being able to get access with some funding or full coverage for certain of these new treatments. But another point that Alex was getting at, or at least I'm going to riff off of, is if you go to your oncologist after this conversation and you ask for some of these treatments and they say, well, we don't do that here, or that isn't proven yet. If Alex is mentioning it here, it is absolutely proven.
It's definitely proven.
And it may very well be that your oncologist has never used it. Or
they just aren't allowed to at their hospital because it's too costly. That's typically what the issue is.
Possibly. And again, even if that is the case, oftentimes with proper documentation, there is a way for you to get access to it without having to pay out of pocket. So don't give up is what I'm trying to squeak in here about. There are so many different ways through and around to get the things that you need. So if you hit a wall or there's any resistance at all, just take that as, I guess I need to get a little bit more information, as opposed to this is a hard stop. That's not possible for you. Don't give up. This is your life. We want you to get the best.
Thank you for watching CTOM TV. Subscribe below and stay informed.